Welcome to our final seminar in the C6 seminar series. My name is Catherine Diskin. I'm a pediatrician that works at the Hospital for Sick Children in Toronto, and I am delighted to be the moderator of today's session. Today's seminar, the whole seminar series has been focused on the clinical care of children with neurodisability and medical complexity. And this is our final session, 10 of 10. We're very grateful for the support that we received from the Lucille Packard Foundation for Children's Health in partnership with Family Voices. Today's seminar will focus on patient engagement in clinical research, and we hope that it will offer an opportunity for reflection, but also on how we can move forward. We really want to thank you for all of your support and engagement over the past 10 months. The seminar series wouldn't have been possible without you. But before we move on, I want to pass to Kate Robinson with Family Voices for a very special tribute to Julie Beckett, an inspirational person and a co-founder of Family Voices. Thanks, Kate.
Thank you so much, Catherine. Yeah, it's really an honor to get to share this. I'm going to share a brief video about Julie Beckett, who died unexpectedly just a couple weeks ago. It's really difficult to even speak about her without getting really emotional, because she had such a tremendous impact on my life, like the hundreds of thousands of other families in the US. Because I was able to bring my baby home from the hospital on a home and community-based services waiver. And like hundreds of thousands of families, and as she was really concerned about up until when she died, still fighting for the folks on the waiting list for these home and community-based service waivers. It meant everything to our families. I mean, it's meant the world. I can work, I can have my child at home to have this waiver. But you'll see in the video, so she was able to get her daughter home at 3 years old. And you would think after 3 years of really fighting for that, you wouldn't blame her for just, raising her daughter. And instead, she kept fighting and kept working, and inspired family-centered partnership everywhere she went. She, in order to get the waivers to the states and expand the waivers, she employed family-centered partnership. She worked so hard to empower other family leaders and to bring folks along with her. And there's so many great stories about her pulling reluctant moms kind of out of their shells and to DC to do advocacy and to be in partnership with policymakers and with clinicians, and really build true family-centered care and family partnership in all of the work that we do. So I'm just excited to get to share this video. You'll see that she was one of the co-founders of Family Voices and helped create the family-to-family health information centers all across the country, and support family-led organizations in doing this great partnership work. So without further ado, I'll go ahead and share the video.
When Katie came home from the hospital, Medicaid established home and community-based services, which they'd never had before, because they never let anybody paid for anybody at home.
The waiver that Julie had gotten for Katie, which was an exception to the Medicaid rule, and then in 1984, there became the possibility that states could apply for waivers themselves.
And then when this happened, Vince Hutchins, who is one of the major players from Iowa, he searched to find me, and we wrote a program in the state of Iowa to help kids come home from the hospital.
When I came into the world of Julie Beckett, Polly Arango, and Josie Wall in the mid-'80s, I had to step into the legacy shoes of Kathleen Bishop, and she had been the one spearheading family-centered care and family professional partnerships under the direction of Merle McPherson, who became the director of the Division of Services for Children with Special Healthcare Needs.
We have a new family-centered model of healthcare that really did respect the fact that families are the constant in their child's life and that they had a huge role to play in helping us change the healthcare system.
We were helping to define what family-centered care meant for, what they would roll out from Maternal and Child Health Bureau at the federal level. It was a true family professional partnership at its core.
In 1992, we had this meeting in December, and we brought in some national organizations, but also individual families from individual states, and we sat in a room. We created the mission and the vision.
The whole mission of Family Voices, that the voices of families are essential to making the changes and improving the quality of life for families, that you cannot do that from the top down. It has to be done from the family level up.
Bringing as many people to the table. If you want a seat at the table, we want you here, and we want to make space and be able to ensure that those voices are heard.
And Julie was always one to, from day one, make sure you're sitting at the table when they're with policy decisions. If you get invited to the table, make sure that you're there. And even if they don't invite you to the table, make sure that you're there.
Julie, again, when we were trying to get the Family Opportunity Act passed, it really was baptism by fire, because she said, you're going to speak, you're going to talk about your family, what you've been through.
You really got the bulk of why you were doing what you were doing. It wasn't just at a personal scale, it was really at a national scale. This isn't just about you and your personal situation, this is about all kids.
When I think about Julie Beckett and I think about the work that she did, it wasn't just galvanizing families, right? But it also was the policy. And I think the importance of merging policy with family.
Julie extends herself to everybody.
And it is just a treat to walk the halls of Congress with her.
And her school teacher self comes out, because we would get reprimanded if we weren't doing what we were supposed to and not paying attention.
The essence of empowerment.
I just thought, yep, dynamite comes in small packages.
Her vision, her dedication, her persistence, persuasiveness, and her ability to love others.
Sentence that's been said many times, but Julie Beckett is a national treasure.
Kate, I don't know if you have anything else that you want to add.
I appreciate us taking that time to reflect on her, and I think going into this conversation, thinking about how we can be partners every step of the way, and focusing on improving care. I'm sorry, I'm totally at a loss. I'm excited for this conversation today.
I think on behalf of Eyal, Rishi, and myself, that when we started this a year ago, we are benefactors of this legacy, because we have learned so much in our partnership with Family Voices, with you and with Cara and with many other families. So on behalf of us, I'm sorry for your loss, but also want to say a very big thank you. And so moving on from that reflection, we also, as this is our final seminar in the series, we want to take another moment to watch another video when we review the series. Again, thank you to the CO Packard and also Family Voices. I would encourage you to take the time that the video allows to reflect on what people are saying, and that it will be used later as we frame the next steps. So Darren and Alyssa, who have created this video, thank you. And I'll be quiet now.
We should always be able to have these real conversations, because we're not going to change anything by, sugarcoating what's going on in our communities.
I think the lived experience can actually help to inform diagnoses, treatment, and the relationships that we form with all of those in our medical teams.
Parents have a PhD in life experience, and we're able to bring that to the clinician, and they respect that. And they're like, oh, you can talk my language. And we have these real, authentic conversations so they get somewhere.
When we designed this seminar series, we thought it was really important to create a supportive forum and a safe space to have these critical discussions that ultimately will help to improve clinical care. In order to do this, we have partnered with families for this series.
Welcome, everybody. My name is Rishi Agrawal.
My name is Cara Coleman, and I am the Director of Public Policy and Advocacy at Family Voices.
My name is Eyal Cohen. I'm a pediatrician at the Hospital for Sick Children in Toronto.
My name is Kate Robinson. I'm your moderator, and I'm a project director with Family Voices. I'm very excited to be here today. About 7.5 years ago, I had a 2.5-year-old and had a child who was born medically complex. And in the past 7.5 years, I've spent many months in pediatric hospitals and had the very good fortune to experience real clinical family partnership.
And so we've had our share of ins and outs of the NICU and the PICU and doctors and specialists, and we really appreciate taking a look at this view and lens of not only from the doctor's perspective but from the family's perspective.
And if we want to improve those outcomes and we want to lower utilization, it's not enough just to create financing mechanisms and complex care programs. We need to improve the standards of care that are delivered to our patients.
So my main takeaway and what I've all learned from it is, while I understand, golden standard treatment is there for a reason, it works for most folks. It's important to listen to the people that know their bodies really well and who are, in tune with it because they've lived with it their whole life. And it's always good to be a little bit lenient where you can in treatment or just your ways of thinking.
So sometimes we don't connect also with what our kids are saying. So I think it's important for all of us to listen, is where I'm trying to get to, is we all need to listen to the patient.
Our youngest son was born, Truman, was born at 26 weeks gestation, so micro-preemie.
So I'm going to focus in on my son. He is 15 now. He has a diagnosis of Down syndrome.
I have a son, Joshua, who is medically complex. We actually just got back from a recent week in the ICU this week.
Our son, Sean, was born with cystic fibrosis. He's 20 years old.
I am, as you heard, the mom of 3. My oldest, Andrew, was born only 5 weeks early, but we found out in the middle of our pregnancy that he had stopped moving, and so therefore developed a lot of medical complex issues.
And I am the mother of Elias, who is a 9-year-old 4th grader now. And I'm also the sister of Brenda Liss, and she is 32 years old now.
Yeah, I'm Maureen, and I'm the mother of George. So George has a spastic quadriplegia from an anoxic brain injury when he was 12 years old.
I'm Kate. I live outside of Austin, Texas with my husband and my 2 kids. And then I have a 7-year-old named Rowan. And Rowan, Kate, you did an excellent job. It's hard to say. She has a rare genetic disorder called recessive dystrophic epidermolysis bullosa. And it took me a long time to be able to say that properly.
My children do amaze me every day. And part of that is because they do have so much to overcome.
I just want to reflect on the relationship piece between provider and family. I think initiating, building, and keeping relationship in this lifelong, because we're in it for the long haul. We have children, then we have teens, then we have adults.
I wish people had more of a relationship with their doctor like I have with mine, because I think that's the key. For me with tone management, it's not necessarily what drugs are out there, it's what conversation needs to be had to do the risks and benefits.
Most of CME, continuing medical education, is focused around knowledge. That's good, that's important. Knowledge saves lives. But communication, that's what I would focus on.
The pharmacists, in my experience, I'm so reliant on the caregivers to be able to provide their story, provide me their history. We have to start thinking about ways we can reduce polypharmacy in many cases. And that really relies upon the parents being involved.
And I'm really interested, before we go to wrap up, if you have any thoughts on how we as providers can be mindful of the parent experience and how much of what we ask is actually an ask of parents and family caregivers.
So parents are the hands, feet, eyes, every other piece that we need in the home and other environments for this kiddo. We have to really work on what you need us to work on. And that means listening and taking the time to listen.
Because you can't help your children if your bucket is just overflowing with your own stuff. You have to be able to triage that and mitigate it. And so for me, that's a big one, is making sure as clinicians or therapists or anyone that's touch pointing with a family that has high needs, just asking every so often, how are you? And being authentic and really meeting it.
And that's why in my mind, I divide the family in 2 groups, like rookies versus veterans. Like you're definitely a veteran here, and which means that you've gone through a lot.
I think the other part that maybe is helpful for families too is we spend a lot of time talking about what brings sadness and what brings anxiety, and taking some time as families to think about what brings joy. So when is their child happy? When do they feel loved? When do they feel comforted? And continuing to build on that to offset some of that anxiety and sadness as well. So as much as we want to assess those things to help prevent them, can we also create a space where they get to do the things that they enjoy, that they like, that bring them happiness?
One of the areas of research is that we're lumping all the patients with complex medical needs or even with neurologic impairment together. And I don't think everyone has the same physiology and as such will not respond to the same interventions the same way.
Knowing that kids are dynamic and it might take a little bit of some creativity, but that's where the individualization comes through.
I think I would just leave you with the idea that we can make a difference.
And I appreciate everyone saying how real this conversation was. I feel it was very authentic. And thank you, Catherine. Thank you, Eyal. Thank you, Rishi. And of course, thank you, Antonio, Leslie, and Tina. I appreciate this so much. And it was fantastic use of the afternoon.
I'm only delighted that you've done my job for me. And I just have to say thank you very much to everybody.
And so it's back to me after that wonderful video. Before we move on to our presentations today, we just want to acknowledge that every healthcare encounter is unique, be it brief or lengthy, and that many of the topics we have discussed over the course of this series, including today, are difficult to address And whilst we cannot cover the breadth of the topic, we really are aiming to highlight the cooperative need and value for partnership at the centre of care for this really important group of children. So a couple of housekeeping things. Please submit your questions and comments in the webinar Q&A. And once we have concluded the presentations, we'll move on to a panel discussion. And we'll be here until about 2:30 chatting about partnership. Following the seminar, you will receive a link to an evaluation survey. It's an opportunity to provide us with feedback. And if you want to claim CME credits for it, Monday, June 13th is the deadline. So like I said, we're here until about 2:30. Please stay on for the chat. And if you can't, the Q&A portion will be included in the recording and uploaded. And so just going back to what the aim of this original seminar series, it was to create a supportive forum and a safe space where important discussions can happen. And we have partnered with families because their participation is really essential to improve clinical care. Families are our clinical partners in care 24 hours a day, 7 days a week, and their experiences and perspectives matter a huge amount. And so by virtue of this forum being large and virtual, the nature of the conversations, which will involve lived examples, we know that this may cause a variety of reactions to resurface. And so we're popping in the chat some resources if anyone needs some extra support, and please reach out to us too. And so moving on to our speakers, we are joined today by Cara Coleman, Dr. Peter Rosenbaum, and Treeby Brown. And their presentations will all focus on different aspects of patient engagement in clinical research. Cara is our opening speaker, and she is the Director of Public Policy and Advocacy at Family Voices National and the author of I Am Justice, Hear Me Roar, about her daughter Justice, with Medical Complexity and Disability. She is the Associate Editor for Family Partnerships, the Executive Editorial Board of Pediatrics, and in the past, Cara has worked as an instructor of pediatrics at a medical school, an adult health specialist, a case manager for homeless pregnant women, a counsellor in a shelter for battered women, a law clerk for a judge, an immigration subject matter consultant, and an attorney serving low-income immigrants. Cara is a graduate of the University of Notre Dame, has a master's in public health from Tulane University, and her law degree from Temple University. Cara is the 2019 Moose Krause Award winner for Distinguished Service from the University of Notre Dame Monogram Club. In addition to this extensive bio, she's also a wonderful teacher and mentor for all of us involved in this. So Cara, thank you very much.
Thank you. I always hate having the bios read, but thank you for doing that. Let's see. Start my slideshow. So I'm super excited to talk to you guys today about some of my thoughts about partnership and team. As Catherine, you got maybe from the bio, I did go to Notre Dame for undergrad. Maybe as you can see over my shoulder, many of you are wondering, what in the heck are those things over her shoulder? I recently changed. I used to have a painting by my grandfather there. But this is some of the last caps I had from Notre Dame and some of my swimsuits. So that's a lot of my fiber of my being, is being a student athlete, a former student athlete. So for me, even though I came from an individualized sport, team is everything. There was a lot that happened in my 4 years of college in swimming, so that, just really solidified the importance of team and how to bring really different people together to, reach a common goal. And so when my second child, Justice, was born with all kinds of disabilities and medical issues, and I first learned about team-based care, I'm like, oh, this is my jam. This is, a whole nother thing. How it worked for Justice was really different. And unfortunately, Justice passed away 5 years ago at the age of 11. But I really believe that, for her, team and partnership and love and friendship and working together were at the core of everything too. And so she pushes me to do that still today. So nothing to disclose, well, except that I do have the partnership and research that I'll talk about is a partnership in home healthcare research with Dr. Carolyn Foster from Lurie Children's, and that's also supported by the Packard Foundation. So a few things that I want to talk about in my few minutes is I'm going to start us off with a poem. and looking at partnership and poetry, and then just identify a few challenges to meaningful and authentic partnership. And then, what are the key principles that we have to activate the partnership? I have on here that we're talking about partnership and research, but this is just partnership, period, that we all have to deal with and have been talking about for the last year. And then some lessons learned and some thoughts from Carolyn and I. So what I did, I actually just started recently in the narrative medicine program at Columbia. So I'm always trying to figure out how to do this and how to bring it in. So I opened Amanda Gorman's new book, Call Us What We Carry. And I just started reading through and I'm like, where is partnership? Where is partnership? I'm not quite sure where it is in the title of this poem, but I thought I would just read it to you guys and ask you to maybe close your eyes or just think partnership. To begin again isn't to go backwards, but to decide to go. Our story is not a circle carved, but a spiral shed, shaped, spinning, shifting inward and outward ad infinitum. Like a lung on the bank of speech, breathe with us. We disembark both beside and beyond. Who we were, who we are, it is a return and a departure. We spiral on, pushing up and out like a growing thing out of earth. Uh-oh, and now the Zoom bar is in my way. In a poem, there's no, hold on, let me go to there's no end, just a place where the page goes wide and waiting. Like a lifted hand, poised and paused. Here is our bond, unbordered by bone. Perhaps love is how it feels to breathe the same air. All we have is time, is now. Time takes us on. How we are moved says everything about what we are to each other and what we are to each other, if not everything. So a few of the words that for me, really spoke to the meaningful and authentic partnership that we can get in research, that we can get in delivery of care or in systems change is, the activation part, to go. The going may be a return, it may be a departure, it may be shedding, growing. That change in that is constant. The change, in our children and the children that you care for, that we raise at home. That's the only thing that's constant, that change in the world and the opportunity of it. And really, most importantly, really the key to team and partnership, our bond, that relationship, the importance of now and being in the moment and everything. So here's a picture on this spiral here. I plopped my Rasta Justy just to introduce you to Justice Hope. This is her last Halloween. At that time, she was really into Bob Marley. So it was an easy Halloween pick for her. And her favorite song at the time was One Love, which also, if that can conjure some words, let's get together and feel all right, that partnership, that love, how we work together. So a few things, when we were planning and thinking about this session, one of the comments that I made, in our planning session was that I think one of the best parts of this seminar series, and one of the most important parts of any of the partnership work that I do nationally is trying to push people to go into the gray areas that maybe cloud us moving forward in partnership, whether that's at the individual level and family-centered care or at a systems change level or in research together as clinicians and families. And there's a lot in there. I'm not going to unpack it all now. I know Peter has a lot of really great words to share on it too, but I just put up here some of the ones that I think are more important and ones that, we need to figure out, particularly in a time where we're calling for health equity, how to sit in these gray areas and not be afraid of them and not push them to the side. Partnering with families at the individual level, at the systems level, at the research level, brings up a lot of fear and uncertainty for clinicians, for families alike. How does this power dynamic work? How do you do this? What is an expert? I always hate when I'm called an expert. I'm not an expert in anything. I have some strong ideas and experiences. And anyway, sometimes I think the way we think about expert makes it seem like there's no place for anyone else on the team and an opinion. So how do you get the dynamics of everyone working together? You know, particularly in research partnership, there's a lot of challenge around what is valued, academic expertise, whatever, I always say it as whatever letters I have after my name. And for me personally, I have quite a few letters after my name, but because I lead with my lived experience, I'm often diminished and those letters are ignored. Does that matter to me? No, but it's part of the power dynamic that we have to work in and sit in the gray areas to figure out how do we get better together in partnership and teamwork. And that lived experience has expertise and value. When we were doing our prep session for this, we all agreed that we could go into a whole session about the compensation of lived experience and what it really means to value and the power dynamics there. You know, that's particularly true in research where the partnership is often around an academic medical center and there's, you know, agendas and there's ladders for professional advancement and there's funding issues and who gets funding and what priorities for funding and overhead and all that. And often that lived experience isn't valued and just brought in as a token way. And that's a quick, easy way to diminish the value of the family partnership. And a lot of people who haven't had the experience of partnering, and that's true for families and true for clinicians, think, isn't this going to muddy the water? It's just going to make things not efficient. It's going to be more difficult. And often, you know, when we think about, well, we need to prep somebody for partnership, a lot of times we say we need to prep families for it and train them. Very true. We also need to prep the clinicians and the professionals, you know, public health professionals, policymakers, everybody else involved, because we're not that great in the end, all of us, in doing teamwork and being able to really acknowledge that fear and uncertainty. And also what I have next here on the list, the trust and the mistrust in the history. You know, we can't in a research partnership, you know, in a Black community, just go in and go with our plan. We have to figure out how to take time and acknowledge the history, the structural racism, what happened, you know, in race-based medicine and continues to happen in the history, you know, of research abusing Black Americans with Tuskegee and others. And that's just one example of, you know, that families of children with medical complexity have a lot of trauma around their experience. And those are things that we can't just go ahead and just hop into a partnership unless we address. Otherwise it will prevent anything being sort of meaningful and authentic. So a lot of these other things I mentioned here, and I know that I'm running out of time, so I'm not going to sit in the gray areas anymore. I'm going to move forward, but just make the last point that, you know, unfortunately, I feel like already that in the last few years, equity has become at the forefront, but then quickly become a checklist and a token thing that we say, another buzzword. And, you know, I really want to argue that, you know, to ensure that we achieve health equity, we've got to figure out how to work together with lived experience, because if we continue to leave lived experience out of the partnership or out of, you know, authentic contribution, we'll never achieve equity. We'll just design systems, you know, and delivery of care and research that doesn't ask the right questions. So, you know, how do we do this? We have lots of tools, lots of approaches that, you know, unfortunately, because of the pressures of time and demands on all kinds of things, you know, care we're providing in the home, clinical care, other things, you know, family-centered care, I think often has become sort of an adjective and a noun. You know, we just place the family in a nice placard on the wall saying we do family-centered care here, or family is at the center and we all stand around them. But how do we actively, from that model of family-centered care and family professional partnership, or how to engage diverse partners in research, how do we activate those and make sure that they're verbs? We have a lot of the tools and a lot of the tricks about what we need to do. It's just taking the time and finding the time to do them together. So my last slide here, and I really picked a very strategic spiral here, riffing off of Amanda Gorman's words of spiraling and continuing to illustrate a few key points that Carolyn and Foster and I talked about, what we've gained and really developed in our 3 years of working together as research partners, is, you know, that all of these mosaics in the stained glass on their own are not going to form a picture, and put together they can form all different pictures, and we keep moving and creating new and adjusting and, you know, continuing until we get to the light. So being co's and doing co's, like, what is this, Cara? That's not even a word, right? But it's my tongue-in-cheek way of talking about, you know, another way of talking about partnership is co-design, co-learning, co-implementation, co-production, all those co's. So how can you be co's and do co's? These are a few of the lessons learned that Carol and I talked about. And really the most important is in the beginning. From the beginning, Carolyn and I thought of a home health care project that we wanted to work on. We identified that, you know, as part of that relationship building, that home health care was really important to both of us, and what aspects of it were really important. And so that took just a lot of relationship building and talking and getting to know each other. And then we designed from the beginning. We didn't, you know, Carolyn didn't write a proposal and 6 months later come and say, hey, will you sit on this advisory board, or what do you think about this part? And those are all really fine, important parts of a process. But for us, that beginning really helped solidify our relationship even more. And really key part of that is that we set up a non-traditional sort of plan from the beginning. There is a budget in which I'd get more than an Amazon gift card. I am paid for my work. I'm contracted through this. And we put in there time, time together, time on the project, resources, and other funding for other families we would bring in and other partners and stuff like that. But that from the beginning allowed us to have it all built in. And then, you know, looking back at the principles of family-centered care and of engaging partners in research, you know, we really view our partnership as this mutually beneficial relationship. You know, as I mentioned, the valuing each person in piece, but there's a give and take that happens. You know, each of us has something to bring to the conversation. I think we say that all the time, but it doesn't always, there's sometimes an inauthenticity to it, because it's more than just, I hear your story. I hear your story, and then I'm going to really absorb it, and we're going to do something about it together. What does it have to do with the research questions that we're asking or the process that we've set up? So that kind of, we have to spend a lot of time working through the science of like our methods and what we're doing, but also being responsive to the flexibility of, you know, what that partnership can bring. We can set up something that we have to work through what it really entails, and it may mean switching directions and really looking at what is evidence, what do we value. A lot of times we value the quantitative and kind of ignore the qualitative, but that's what a lot of what families and family leaders bring, and that qualitative is really critical. So I think, I mean, the other ones, I know I'm out of town here, so I'm just going to stop with that. The other one that I'll just harp on, one last thing, so sorry I lied. So I was inauthentic, there you go, is just to hammer home the point of the authenticity and the vulnerability. You know, in Carolyn and I kind of talking through some of the things we've learned, you know, we took time, you know, she took time to get to know Justice, even though she never took care of Justice, and Justice is no longer here with us. And I know her children, and that's the personal, and that gets to the gray area and the uncomfortable, like, where are the boundaries here, right? But that's part of learning to, you know, work together and develop team and partnership. And I know where she's going in her career ladder and her job, and what she's thinking and what other projects she's working on. And so then we start bringing, she knows that for me too, and we start bringing in and other stuff. And we're not afraid then to bring up an idea to each other. And, you know, that takes time, and it takes relationship building, and it's teamwork. So anyway, that is all I have to share. Hopefully those were some interesting words, wise words, probably not as wise as Amanda Gorman's, but there you go. And now I'm passing back to you, Catherine, right?
Yes. Always wise, Cara. I found myself nodding along with you. Um, I am now going to introduce Dr. Peter Rosenbaum, a professor in the Department of Pediatrics and an associate member of the Department of Clinical Epidemiology and Biostatistics at McMaster University here in Ontario, Canada. He held an inaugural Tier 1 Canada Research Chair from 2001 to 2014. And in 1989, Peter co-founded the award-winning CanChild Centre for Childhood Disability Research, a health system-linked research unit now recognised worldwide for its research and dissemination activities. And I can personally vouch that as a paediatrician, I use its output all the time. His research areas focus on childhood disability, family-centred service, family well-being in families of children with complicated lives, measurement and the functional classification in childhood disability. Thank you, Peter.
Thanks very much, Catherine. I guess I should thank Catherine, Eyal, and Rishi for this. I didn't realize that I was going to have to follow two very compelling videos and then Cara, who said most of what I'm going to say. So I'm going to try to be brief, but I will share some experiences of both my own personal engagement in research with families and some of the things that we're learning at CanChild. I think it's important very briefly to recognize that we've come from a 20th century rooted in biomedicine, and the field of child health has moved enormously forward in the past 100 years. And I suspect that some of the children of people who are listening wouldn't have lived 100 years ago. And that's a tribute to the changes that we've made in the technical side of things, but there's still a lot of work to be done. And this is a quote from Sir William Osler, who actually was born down the road from where I am right now, who said, "The good physician treats the disease, the great physician treats the patient who has the disease." And of course, in our situation in child health, we're talking about the parents as well. So where are we? The 21st century has seen the introduction from the World Health Organization of its international classification of functioning disability and health. And again, this is not a talk on that topic, but it's very important to see that modern thinking about health reminds us that any health condition has manifestations in body structure and function, but also likely affects people's ability to do things in day-to-day life called activity, to engage in life in ways that are meaningful to them called participation, and by the way, that they're individual, that the personal factors are essential to understand for this particular story, and that environmental factors, of which there is a vast number of social, political, and human and attitudinal and so on factors, are also hugely important. And these are all interconnected. 10 years ago, my colleague Jan Porter and I put together some ideas to try to bring the ICF to life. And we wrote a paper called The F Words in Childhood Disability. I swear this is how we should think. And the F words, which are in the bigger boxes, are meant to animate the concept. So we talk about fitness, physical and mental well-being. We talk about functioning, however you do it. We talk about friends with respect to participation. With personal factors, what's fun for you? And with environmental factors, the quintessential element of environment for children is family. And we added future to remind people that when we're talking about child health, we're talking about a work in progress of children and families. And these ideas, I think it's fair to say, have not been thought about in this way. And you may be wondering, what's this got to do with the topic? And the answer is everything. A parent said to me a couple of years ago, "You have textbooks, we have storybooks." And this led me to write an editorial. And I suggest, if you really want to hear Elizabeth in person, go to this website and listen to her podcast about these ideas and the conversation we had. Fundamentally important to how we think. And Elizabeth was at that time a parent in a research study we were doing. She's now an active colleague with us as a parent. So we have to wonder, why have we taken so long to kind of come up with the obvious? I hope that in 2022, whether you're a researcher or a clinician or a reader of the literature or any kind of professional, you will recognize that we have a responsibility to seek the advice of, to listen to the ideas of, to consider the implementation of the ideas of, and to engage with them. And them in our field is the people who know from lived experience. And of course, we're talking about parents, and we're talking about young people to the extent that they are able and willing to offer their perspectives on things. Some of the issues are that as a professional, I know what your issues are. And the answer absolutely is you do not know what my issues are. You've not walked in my shoes. And even if you are a person with an impairment or a parent of a child with an impairment, you know, as they say, one story. So we really need, we service providers in doing research and in being clinicians need to understand their point of view, they, the parents. What are we wanting to study? Well, there's an infinite variety of things to study. What are the issues in scope for us? But particularly if we want to know what is important to families and their well-being, we need to engage with them. We need to study the issues and can't do that without insiders' views. And there's a huge energy in the community to do this. And PCORI was mentioned earlier as one example. I'll give you just a couple of brief examples from CanChild's experience. We started in the early 1990s to explore what family-centered service meant, and particularly how to measure it. We did this by engaging leaders of parent groups, and we ended up with a 71% response rate from 280 parents. And that was because the people who were helping us, the parent leaders, were extremely persuasive and extremely important to what we did. 71% response rate is insane. Never happened since. We use the findings then to go to parent groups and say, people like you told us that such and such is important. What does it look like? What are you experiencing? And the best accolade we've ever had is, this is a good measure, say parents. You're asking us great questions, and our answer is, of course we are, because people like you told us what to ask. So that kind of validates the importance of knowing how to look at things from the perspective of the people whose opinions we ultimately want. We currently have two large Canadian Institutes of Health Research funded studies going. One is called Envisage, which a parent has referred to as early intervention for parents. Another is a redevelopment of our original measure of processes of care, our original measure of family-centered service. And in both of these studies, parents are named co-investigators, they are named co-authors, they are co-developers and co-presenters of our work. And by the way, lest you think this is just a Canadian thing, all of this work has been replicated, and this approach has been replicated by one of my PhD students in Croatia. And she's done exactly what we've done and engaged in the same way. There are, however, and Cara alluded to this, she was really reasonably polite. I wouldn't be so polite. How do we recruit people? Are we representative? How do we get cultural, linguistic, and socioeconomic factors to be represented in what we do? What is the currency for recognition? When I write a paper, I impress my chairman and I get promoted, and I might even get more money. What do we do for parents? What's important to them? And we need to find out what's important. It may be any combination of money and recognition and support for the things that are important to them. And can we be flexible and individualize that recognition? And it is extremely difficult still, despite granting agencies and ethics boards and so on, expecting patient and public involvement, they are not really very supportive in terms of putting their money on the line. And we have some work, we're struggling with these issues. Some work has been done by a group of our graduate students, and there's a paper under review, which has looked at what people are currently doing to recognize the contributions, the input of the people who matter in the way that we're talking about. But ultimately and collaboratively, and this is where leadership from the researchers comes in, we need to inform agencies, research ethics boards, and administrators and policymakers about this, because otherwise this will continue to be, with our best intentions, continue to be token. I'm going to stop at this point. I know there's another presentation, and then we'll have a chance to discuss things. So thank you very much.
Thank you, Peter. And exactly, we're all here till about 2:30 to discuss this topic after Treeby speaks. So that's just a reminder to me to remind you to pop any questions that you have in the Q&A. And it is my pleasure to introduce Treeby Brown, who is an Integrated Services Branch Chief in the Division of Services for Children with Special Health Needs, the Maternal and Child Health Bureau at Health Resources and Services Administration. Previously, Ms. Brown was a Senior Policy Analyst at AMCHP for 6 years, and she's also worked as a Legislative Analyst for the Governor of North Carolina, a Press Secretary and Legislative Assistant for a member of the U.S. House of Representatives, and holds a Master of Public Policy from Duke University. So Treeby, thank you very much.
Great. Hello, everyone. It is always tough to be the bureaucrat who is following the powerful provider and family presentation. So I don't know that I'll be as riveting as my colleagues, but I'm hoping to talk a little bit about the federal role in promoting programs, policy, and research that support patient and family-centered care for children with special healthcare needs and for children with medical complexity. I'm not a clinician. I come from a federal and state policy lens, having worked at the state level and then for many years at an organization that supports state maternal and child health programs. But I do know about federal programs and how to promote emerging issues, and we can advance to the next slide, and how to engage with families and providers to address issues that are important to them. So I'm going to talk a little bit about MCHB and some of the strategic frameworks that guide our work and how we've tried to incorporate this work into our programs, and then provide some thoughts about moving forward, and really looking forward to your questions and comments. So we can advance to the next slide. A little bit about where I sit. I work in the Maternal and Child Health Bureau, which is a part of the Health Resources and Services Administration, and that's part of the U.S. Department of Health and Human Services. And our mission at MCHB is to improve the health and well-being of America's mothers, children, and families. We have 4 MCHB goals. We really try to take a life course approach to improving health. We do this by gathering data from our grantees to track progress. We try to lead and engage with states and communities and families. And we really try to look in our work to other factors that affect health beyond medical care. So specifically, I work in the Division of Services for Children with Special Health Needs. I'm the acting deputy right now. And at MCHB, we have a broad definition of children and youth with special health care needs, and children with medical complexity are a subset of this population. At MCHB, I do feel like I walk in the shoes of giants like Merle McPherson, who you heard about in the video. And for my Canadian colleagues, Merle McPherson is originally from Saskatchewan. So just know that you're influencing our work across the borders. It was also my great pleasure to know both Julie and Katie Beckett. And I will say that Merle McPherson and others like her, they really knew how to work with advocates like Julie and to build those visions into a system where families are at the table. And hopefully we try to have that continue to guide our work at MCHB. We can move to the next slide. Our division funds a variety of programs across the United States. They're demonstration projects for epilepsy, sickle cell, and autism, newborn screening programs, programs for peer support and family engagement, the family-to-family health information centers that you heard about, and national technical assistance centers, as well as some work for children with medical complexity. And we also work closely with state programs that serve children with special healthcare needs. We specifically have a tradition of working and engaging with families and those that serve them to build programs and support initiatives for things that we know are important to families. We don't fund big clinical research studies like NIH, but we rather we choose to look at approaches to healthcare that families value, like team-based care, telehealth, transition planning, and engagement of families. So with our limited funding, we really try to be strategic in what and how we fund programs. We're never static. It's a constant evolving process, always an emphasis on innovation, impact, equity, measurement. We don't always get it right, but we're always trying to improve. And, you know, what I would also say is that we know we're not always the experts, which is why we engage with families. It's why we fund technical assistance centers like Family Voices, where we have the leadership and family professional partnerships, technical assistance center, so we can help identify emerging issues and provide expertise. And so as we move forward, I just wanted to highlight a couple of key frameworks. One is at the bureau level, we are guided by our MCHB strategic plan. And I think we saw the slide about that before. For children and youth with special healthcare needs specifically, we are guided by our blueprint for change, which just is hot off the presses. It was released yesterday, and under the wire, we got a press release at the HHS level. So it's a really high profile, we're hoping, national framework for a system of services. And I will say that some of our colleagues here, Cara and Rishi, were authors for articles in the supplement and really helped guide our work. We were driven by this work by an ongoing data point from our National Survey of Children's Health that said that of the 1 in 5 children in the United States who have a special healthcare needs, 85% of them do not receive care in a well-functioning system. So we're really struck by that. So how do we look at the system differently? And so in the fall of 2019, we began working with a small group of experts, families, providers, academics to re-examine the system of care and to identify priorities and opportunities. And we came up with these 4 areas: quality of life and well-being, access to service, and financing of services and health equity. And I say these because our programmatic work really informed the development of this framework, and it also, we hope that this framework will inform our programmatic work. So we can move to the next slide. So there are 4 areas that are all interdependent. And what is new about this, or we hope is new, is a real focus on healthcare systems to measure outcomes that are meaningful to children and families. A priority on addressing upstream and downstream factors that really prevent children and youth with special healthcare needs from a fair and just opportunity to be helpful, and a call to design a system that's built around the needs of children and families, not just a diagnosis or treatment protocol. So we realize they're very aspirational goals, but you know, you got to write it down somewhere, because if we have it written down, that puts a stake in the ground. So we really do see this blueprint as a tool to help the field. It helps highlight the national leadership of our Bureau, but it also provides principles and recommendations for the field. And so I hope that you will all take a look at it. There are some we'll provide the links in the chat. So I shared a bit about that because our program and our strategic frameworks really influence each other. With limited funds, our blueprint helps us focus on what is really important to families, and our programs help us understand how these issues play out at the state, local, family, and clinical level. So we can move to the next slide. That is a lot about frameworks. We like frameworks. But I also wanted to talk about a couple of key programs that have a focus on children with medical complexity. The first is our Children with Medical Complexity COIN. That's a term. It's called the Collaborative Improvement and Innovation Network. And again, many of you have been involved in that. I know some of your previous speakers in this series have been a part of that work. But it was our HRSA's first program that focused specifically on the population of children with medical complexity, with a goal of improving the quality of life for children with medical complexity and well-being. When we recognized that children with medical complexity needed a more robust model of care, and that the systems of care approach should be comprehensive. And in setting up this program, we also realized that the teams needed to be broad and include family members and caregivers, pediatric primary and specialty care providers, state Title V leaders, Medicaid leaders, healthcare delivery systems leaders, and children's hospitals. And work on our CMS side influenced this work, as did some foundational work that the Lucille Packard Foundation did. They did a big supplement on children with medical complexity in a symposium, and that impacted the development of this work. I also want to call out a specific impact of the Children with Medical Complexity COIN work was the focus on family and child well-being and quality of life. That was directly influenced by the conversations that came in this work. And Cara was very gracious to take time she did not have to author one of our articles. I say that again because we're always evolving. This iteration of the COIN ends in July. Our next iteration of the program, taking lessons learned from the current program, is structured slightly differently with a coordinating center and 5 demonstration projects, all of which are family centered. Again, focusing on shared decision making, improved family and patient experience of care, and a number of specific requirements about families and caregivers as leaders in the system and as members of the advisory committee that advances this work. So we can move on. I wanted to so this is the next iteration of the COIN that I talked about, or we're no longer calling it a COIN, but it is a program on children with medical complexity. And we can move on to just another program that I wanted to highlight because of where it's going in the future and its impact on patient and family-centered care. We have been funding a children and youth with special healthcare needs research network since, I think, 2017. The next iteration of that will be starting in September of 2022. It's not a huge amount of money in research world. It's $1 million, but things are a lot bigger than that. But it's been very impactful because one of the things we asked them to do was develop a national research agenda to help guide and focus our work. And they did that. They also published a series of papers that dived into these issues on their research agenda even more. And they also developed a set of guidelines for family compensation and research projects. So a lot of really great work. The next iteration, again, learning from what we had from this project is a little bit more focused because now we have the research agenda, but it's going to be focused on measures of well-being and quality of life in clinical care and public health settings, research around integration of care and services across sectors, and also the effect of partnership and engagement on children and youth with special healthcare needs and their families. So we're really excited about where this research network is going and what will come out of it. Another kind of structural piece that we built into this was that at least 20% of the Research Network Advisory Board should be comprised of youth and young adults with special healthcare needs, families and youth with special healthcare needs, and advocates. So building some of those requirements into our programs, and we do in all our programs have some level of requirement for family engagement, but we're realizing, the more that you have real structural requirements, the easier it is to promote consistency across programs. So I guess as we look to the future, we don't always get things right. We're constantly evolving, but we're looking forward to a body of evidence about measures of family engagement and quality of life and well-being. We're looking for that information for demonstration projects. We need your insights and ideas. There's no wrong door. I would say, as you think about how to promote work, get to know your family-to-family health information center, get to know your local, state, and territorial public health departments, publish anything, anywhere, a commentary. It doesn't have to be a super complex research project. Get involved with your professional associations, and just know that there are many paths to start this work and to make your impact known. And I'll stop with that. Thank you.
Thank you very much, Treeby, and indeed thank you to Peter, to Cara, and Kate earlier for all of your preparation for today. For the next 20 minutes or so, we're going to have a panel discussion. Please use the Q&A box to open it up if you have any questions. And perhaps, Treeby, you framed my first question to each of you, thinking about partnership with family and with patients, not just in research, but the whole field of care to children and youth with special healthcare needs. What things would you like to see happen soon? How do we start this work? Cara, Peter, I don't mind who goes first. Peter, maybe?
Well, I'd like to see the people who expect us to engage with us as researchers to engage with families to be very clear what they are prepared to support with respect to recognition for families. One specific example at our university is we can't pay families because they're not employees of the university. Now that's an administrative nuisance that can be fixed. But if people are going to be serious about this, then they need to put their money and their administrative muscle where their mouth is. And it's pretty frustrating to try to do this and respectfully engage with families who want to be engaged, and then not to be able to recognize them properly for their work.
Yeah, I agree with Peter. I think it's what I hear in what he's describing is sort of the culture change that needs to happen. And culture change maybe with teeth, right? Where it's not just that we change and we have aha moments, but that we actually go into the nitty gritty and the processes and the policies. Often we talk about policies in the US and we think, oh, Congress, but there are so many more impactful policies, at the state and local level and hospital and other that will really change how all of this is done and make things go forward. And I think, I just wrote down the note. The other for me, culture change that really is in there though, is back, I guess, to the aha moments, that we have to make time and find space for those gray areas so that we talk about and really identify, Peter's ideas of what needs to change may be different because he's coming into the research and organizing differently than a family coming in. And so making that time, as they've done at CanChild, to have those conversations, is a time thing. But the other culture change thing that comes up is just, I wrote down in swirling, and it's always been one of those statistics that really gets at me, that Treeby said that 85% of our kids with special healthcare needs don't receive care in a well-functioning system. That's awful. I mean, plain and simple. And that's what we do and what often comes out in research is we're trying to figure out how to look at that. And we've identified caregiver burden, but often that caregiver burden is looking at the wrong things. When I hear that number of 85% of kids don't receive care in a well-functioning system, I hear system burden. And that's what I know I've experienced personally. That was the stress of my life, not my child. And, the way that we ask the questions and the research that we create and the evidence and the policies and the processes that don't allow us to make some money while we're helping and contributing to a research project and be valued that way, just all of that is system burden. And system burden that not only, I'm really getting on a soapbox, I'm almost done. The system burden that not only affects patients and families, but also affects the providers in the most broad sense, the clinicians and even those public health and therapists and other people that, are really struggling, in the pandemic, but before, the quadruple aim with physician joy, lacking and burnout and frustration with the system. And so we have these sort of shared moral distresses and shared system burdens, but often we don't come together and look at it. So I took it in a totally different way and probably not what you wanted, but there you go. Treeby, your turn. Any thoughts to Catherine's question?
Well, I will say, please read Cara's wonderful article about family and child well-being and quality of life, which is in the blueprint. And I will say that, having things written down and published really helps us, at least having things written in a funding opportunity with structural things really helps. One thing I see at the federal level is that sometimes there are differences in interpretations. And so people or states may put a barrier that actually doesn't exist, but they're interpreting it that way. So thinking about how we can help, might be related to data sharing or, how you can measure something or employ something or compensate someone. And so I think on our end, to the extent we can be as clear as possible on the flexibilities and the restrictions we have. So there's certainly things we can do in terms of what we write into our programs, but also that clarity there.
Thank you, Cara. I had no expectation of answers, and it sounds, looking at the chat, that you hit it out of the park with comments echoing, system burden versus caregiver burden, and echoing a lot of what you said. Candy does too. And maybe related to what you have said, there's a question in, and it says that the research agendas often are still mostly driven by researchers, and then families are asked to support the already developed research agenda. And so how or when do you see patient voices during research agendas and solving problems meaningful to them or to us? I think it's getting at early involvement and early engagement in developing of research agendas. And I think we have 3 experts who will definitely have thoughts on this. Cara, do you want to take this one first?
Sure. The easy answer, right, is like the one I tried to be dramatic and say in the beginning, but it does have to be that way. And I think it gets to one of Peter's points on his slides was, how do we recruit parents, right? He built CanChild to do all kinds of research, and that was part of the structure. So sometimes people say, well, we have to recruit now, especially in a time of equity. Family Voices gets all kinds of requests like, oh, bring us some research partners. Oh, and by the way, they need to be brown, this shade of brown, have this language, have this, and this. No. That's not how it works. And, just as you can't pick a researcher off the street, you can't just pick a family off the street, but you also can just, the sort of the flip side is sometimes we hear, well, we can't ask families to do that because they're so overwhelmed and burdened. But you can ask because you don't know what the answer is. It's really one of the most, if I can be frank, ridiculous responses, because I know for me personally, being able to be active, for me, it was medical education. For me to be able to learn how to teach and impact the future of physicians while I was navigating absolute chaos in my child's life in a system that made no sense. I had no time for it or energy, but it was so life affirming and helped me deliver care, in a different way. So I made time, and it just took one person asking. And if you don't ask, then you lose out on that. But I think one other thought too that I had, and I just lost because I went on a soapbox again and lost, is that there actually are lots of structures in different places that you can go to, and hospital advisory boards, or as Treeby said, they fund these family-to-family health information centers. There are family, community-led places and structures everywhere, and that's such a great place to start and develop the relationships and build from there. Yeah.
Peter, I think you had something.
Well, I'll make a quick comment and then another quick comment. The first is that what Cara just described is what is said, like we can't ask parents because they're too busy. These are people who would swear on the Bible that they're family-centered. And that's absolutely nonsense, that they're not family-centered if they don't ask families. Families can say no. The second comment I would make is that with respect to where does the research come from, I think it has to come from particularly from researchers who have interests in these areas and want to develop questions about what we do, how we do it, whether it matters, and so on. And then from the beginning, engage families. Most families aren't researchers. They're extremely valuable resources, but the researchers have a responsibility to ask good questions.
Treeby, I don't know if you want to add anything.
I mean, I'll just add that at MCHB, again, we have sort of limited dollars. We have research networks, which are relatively small compared to like big clinical NIH studies. What we can do is sort of lead by example in the areas that we choose to focus our work on, the requirements that we have for family engagement and participation, and in the, and how we assess the success of these programs.
Thank you. And I just want to comment on two things. I see Francine has popped in the chat about being a parent, but my time is advising. So I think that's echoing Cara's comment for us as clinicians and researchers to ask rather than make presumptions. And there's also a comment around a recommendation for a TED Talk from Sarah. And I will get to Linda's comment. I just want to put another question to the panel. As someone who's beginning to do this work or has been doing it and very kindly mentored by Cara and Kate and many others, one of the things we've had conversations is how do we make this a safe environment for families and for clinicians and researchers to come together. And we've talked a little bit about preparation and time, but I'm just wondering if you have wisdom to share with those in the audience around how do we deliberately create a safe environment for patient and family participation in research or education. And again, I don't mind who goes first. Peter?
Park your ego, be prepared to listen, recognize that we have an awareness of the issues, which is why we're starting to talk about them, and then listen to how people experience those issues and how they would advise us to study them. A comment was made, I think, by Treeby about the qualitative dimensions of our work, and I cannot but underscore that point that we need to do qualitative as well as quantitative research. We need to hear the voices, we need to interpret the voices, and this is what we've been doing in our Envisage study. And the complementarity between what we measure with questionnaires and the themes that emerge from the parent voices is very strong, and each enhances the other.
Yeah, I think Peter knocked it out of the park with that, that even that I feel like in the seminar series have gotten more open and being able to say, park your ego, because that is a really gray, murky area, and it's a power dynamic that infiltrates all of that. And, you know, clinicians and others have worked very long and hard for their degrees and stuff. But if you really want to get to, you know, great questions and answers that help the field, you're going to have to park your ego. And you're going to have to be, I think, having the conversations in the way that we've been able to set them up as honest. And people feel that they can say, you know, what they really want. If you're just thinking of individual relationships, you know, clinician caring for a child, those are really challenged, sometimes power relationships where we often feel that we can't say from one end or the other what we want. But, you know, having seminars and series like this and more opportunity for honest conversation where people can be vulnerable and say, I never thought of it that way, or I did this and I thought this way and now this. You know, I think it is, I mean, I think it's paramount and part of the movement in this time of equity, whether we all heed the call, you know, and check our privilege and other things at the door is another thing, but I think we're making great steps.
And I just want to highlight Erica's comment that, you know, the environment isn't just about being safe, but an equitable and accessible one, and that the virtual space provides more potential for more opportunities. Linda and Laurie have kind of touched on something that has come up a little bit throughout this conversation around remuneration for patients and families engaged in all types of work. And I think it's not an understatement to say that that's a challenge for many of us. And again, I'm interested in practical things that people can do to kind of start this conversation or to move it forward. Treeby, I am going to start with you because you got called out in the chat.
I mean, I will say in one of our programs specifically, we do have a call out that 25% of the budget has to go towards family engagement and family support. And that's in our hearing screening program. And I think that's, you know, help moving the system along. So that's one sort of concrete thing. I think also really being clear about who is on your advisory committees and who, you know, again, at the beginning, who is helping devise these things.
One of the things
again, we haven't figured it out, but these are our approaches so far. So
one of the things that I'm prompted to do based upon these conversations is to go to our to the budgeting office that manages research accounts and find out how we can get past the barriers we now have so that we can recognize people financially, even though they are not researchers in a formal sense, and even though they're not graduate students, and even though they're not faculty members. You know, I suspect these are resolvable problems. And what we're probably stuck with at this point is that this is the way it's always been done. And we haven't had this question come up. And so we don't have an answer for it. But if the question comes up and is addressed, I'm sure it can be answered.
And Peter, Laurie has put a suggestion in the chat around patient partners program through Diabetes Canada, and that they're working with UHN, one of our big hospitals in Toronto.
Thank you.
Cara.
Yeah, you know, of course, mine is not going to be as tangible, or my first thought on it is not the tangible one. It's again to a culture change thing, because I think the way that we often think about compensation is compensation for time, right? And so, you know, because we're always worried, like how much, you know, that the family, you know, or young adult or youth is not going to have time. And there's the boundaries there. We're always thinking of, and because it's important to communicate, what is the time commitment, what's involved, right? But we stay stuck in that mode. And then we think, okay, it's 2 hours a month and therefore a $50 Amazon card. We're thinking about it in terms of time. You know, and if we just flip and think about it in terms of value, because everybody in this series has said again and again, you know, what families have given to us as there was an emerging investigator that was here in the chat saying invaluable. Do you pay $50 Amazon gift cards for invaluable? No, you have to shift the culture, to what is lived experience. Can we define, what lived experience? Is it an expertise that delivers something that, deserves some sort of equal compensation? And so that gets into what Peter is saying about, going to the budget office and stuff. In my medical education work, I know that I struggled to get paid and worked really hard while, nurses and PAs would come in and lecture and get paid by the hour and swipe. And I'm like, I'm doing the same thing. How come I'm not getting? So we, there wasn't, a faculty appointment I got, but it had to be at a different level, so we found some workarounds though. And then that demonstrated, okay, she can get this stipend just like an adjunct professor, and then we can build from there. So I guess the tangible in it is if you can't go right at the head like Peter's going to do at the budget office, you can figure out within a department slush fund, is there a way to pay, and then demonstrate in that qualitatively what this person delivered, in the paper they wrote and everything, and then make a different argument. So.
Thank you, Cara. I wanted to finish on a note of hope, and I think, Cara, if we were to look back at the last year, what we wanted was collaboration and conversations, and the chat and everybody's participation is reflecting what we had hoped for. So my final question in like 30 seconds is that when you think about family and patient partnership in clinical care, what gives you hope? Like, what are you hopeful for? What gives you a good feeling at the minute?
Looking at where we come from.
Yeah. Okay. Cara?
No, I agree with that. And I went to the last word of that poem, Closure, everything. I mean, everything is hope, together, or the first song that we had, Lean on Me. That's what this is about. We're everything to each other, and often we ignore each other. So stick to the everything. Partnership is everything.
So where we've come from and everything. Treeby, what do you think?
I'll just add the lean on me. I feel like keep leaning, keep pushing. We need you to make us uncomfortable and to be asking us the hard questions. If we are not comfortable with that, we're not comfortable with the gray, we're not in the right profession.
And on that wonderful note, I know lots of people are popping resources in the chat, but I just want to say thank you for everyone who joined us today. I really hope, and I hope on behalf of all the panelists, that you have enjoyed it as much as we have. We definitely have enjoyed preparing for today. And thank you to Peter, to Treeby, and to Cara. Please fill out the evaluation. June 13th is the deadline for CME credits. We hope that you have a wonderful seminar. We hope that you've had a wonderful seminar, but also a wonderful summer. I'm getting my words confused. And thank you all very, very much for joining us. And please keep in touch with us. We hope to keep going with some of this work. So thank you very much, and take care.